Hello, everyone. Welcome to week 6, where we're talking about preparation, screening, and safety. And that includes what are considered clinically vulnerable populations. So, the first reading we have for the week is the role of the guide, and let's talk about it. So, the first reading is from Mary Casimano's experience at Johns Hopkins University as a primary guide in psilocybin studies. What's important for us is that she isn't just describing, quote, being in the room. She's describing a continuum of care that begins before dosing day and continues after. A key takeaway is that the guide's role is not to provide insight or do extensive intensive talk therapy during the psychedelic state. Instead, the guide helps create the conditions for safety and surrender because that's what allows the participant's inner process to unfold. Also, notice the subtle reframe. Non-directive doesn't mean disengaged. It means a guide isn't steering content, but they are highly active in structure, containment, monitoring, consent, comfort, and responsiveness. So Casimano's chapter is basically a map of the full clinical container. Screening isn't framed as paperwork, it's the beginning of trust. The participant is assessed and also educated, supported, and given space to decide. Preparation is substantial, 6 to 8 hours, because the treatment relies on set and setting. Sometimes it can be underestimated, like this preparation phase can be underestimated. In psychedelic work, prep is an extra, it's part of the intervention. During the session, the guide's job is to protect the inward process, keep the participant safe, and intervene primarily to support surrender, not to interpret. Then integration is what helps translate an extraordinary experience into changes in daily living, relationships, and self-understanding. So the author emphasizes that screening is emotionally and clinically meaningful. It begins with careful phone screening, and yes, part of the purpose is to identify who is unlikely to qualify early. But the other purpose is to establish the tone of the work, transparency, psychological safety, and informed choice. She describes cancer and depression studies where screening covers not only psychiatric history, but cancer treatment, medication, side effects, and family history, because risk isn't only psychiatric, it can be medical and situational. A major clinical point for you as a master's level clinician is screening is also where you watch how a person relates to uncertainty, authority, and fear, and you communicate that they have agency. Some people decide not to proceed, and that can be a healthy decision, not a failure. This is where the research context matters. In John Hopkins trials, in-house screening is extremely comprehensive. Medical evaluations, psychiatric interviews, EKGs, blood work, and a lot of measures. This was very similar to the work that I did at UAB. So Casimano underscores a key balance. Classic psychedelics aren't associated with physical dependence in the typical way, but psychological risk is real. Panic, paranoia, destabilization, traumatic material resurfacing, things like that. So for you, the ethical heart of screening is not can they tolerate it, but do they truly understand what they're consenting to, and is the container adequate for their needs? That's a different stance than pushing forward because someone is, quote, motivated. So at Johns Hopkins, they use two guides who stay in the with the participant across prep, dosing, and integration. That's exactly what we did at UAB. That continuity matters because altered states amplify relational cues. If someone feels uncertain about who's in the room or what's happening, anxiety rises. Casimano also notes that the whole team contributes to set and setting. Even small interactions, administrative staff, physicians, coordinators can either increase safety or trigger mistrust. For clinicians, this is a systems point. The participant's experience is shaped by the entire environment, not just what the therapist says. Casimano gives a very teachable structure. Prep is long and it has three clear goals. First is building trust and rapport because surrender depends on felt safety. Second is logistics, because confusion about rules, time, bathroom, music, etc. can become panic in session. Third is psychological readiness, normalizing the range of experiences and rehearsing how to respond when fear arises. She also highlights something students miss. Placebo sessions can be emotionally hard. If someone expects fireworks and gets nothing, disappointment can become despair or agitation. So, treating all sessions seriously is part of safety and respect. Students often hear set and setting as a slogan. Casimano makes it concrete. Set is the participant's mindset, things like beliefs, expectations, fears, and intentions. Setting is not only the room, it's the relational climate, things like procedures and predictability. A key clinical idea is that preparation is where you shape set and setting. You normalize uncertainty, rehearse coping, reduce surprises, and co create a shared language for what to do when things get hard. So, for practice, if you ever find yourself thinking prep is boring, this chapter argues the opposite. Prep is the treatment working before the drug is administered. Casimano goes into granular detail on logistics because predictable structure reduces threat response. People in altered states can become disoriented quickly because uncertainties can become big fears. Some examples: they review what to eat, what to avoid, what to wear, what to bring. They take the participant's phone and shoes not as punishment, but to reduce elopement risk and help them let go of the outside world. She even jokes, "So you can't run away," which lightens the moment while still signaling the real safety concern. They have participants practice the eye shades and headphones position and music track in advance. That practice can surface trauma triggers, and when it does, it's a gift because you can adapt before dosing day. They even changed bathroom protocols after someone got lost. That's a systems learning point. Safety procedures evolve from real incidents, not theory. Casimano treats intention as important but not controlling. In prep, you explore why the person is here, what they hope to shift, what they fear, what better would look like. That can organize motivation and meaning. But then she makes an essential point. Once the session starts, clinging to intention can become a control strategy. The stance becomes set the intention, then release it. She also flips it back onto the guide. The guide's intention shapes the whole relational field. If I'm sharing to impress, rescue, or prove competence, that changes the atmosphere. If I'm changing to support, to be present with no strings attached, it lands differently. So for trainees, that's a person of the therapist lesson in disguise. So this is a core safety section. She explicitly tells participants that frightening experiences can happen: fear of insanity, ego dissolution confusion, paranoia, depersonalization or derealization, body distortions, and feeling fragmented or dying. Notice the clinical stance. She normalizes these possibilities without catastrophizing. This reduces shame and surprise. She also discourages over intellectualizing. In high dose states, the thinking mind can spin and worsen anxiety. The strategy is acceptance. Stay with what is happening, let it move, and allow it to pass. She also notes humor can lighten, but it must not invalidate. For students, that's a relational attunement skill. Levity is connection, not avoidance. A key training point: many people assume psychedelic therapy is like intense processing while intoxicated. Casimano says the opposite. It's largely nonverbal, inward, and talk can distract or mislead. Guides check in, but the purpose is safety and orientation, not analysis. However, an important nuance is that there are exceptions. She shares a case where a participant needed to talk continuously for over an hour, and stopping her would have been countertherapeutic. The participant's line is memorable. Sometimes you have to tell your story to transcend your story. So the takeaway is have guidelines, but don't rigidly enforce them at the expense of attunement. Casimano treats transference as expected. In altered states, participants may project fear, anger, or mistrust onto the guides. The general approach is not to litigate it, acknowledge, don't defend, encourage inward intentions. I'm sorry, inward attention. But she also named something crucial for ethical practice. Psychedelics can heighten sensitivity to interpersonal cues. If a guide is distracted or distant and the participant senses it, the worst move is to deny it. That breaks trust and destabilizes the setting. In her example, a guide admitted he was preoccupied, apologized briefly, and the stalemate resolved. For trainees, this is relational repair in real time, simple, honest, and not self-indulgent. This is a major safety and ethics section, especially with vulnerable populations. Touch can be profoundly regulating, things like hand holding or a supportive presence, particularly when someone feels alone or terrified. But because psychedelics increase suggestibility and attunement needs, touch is also high risk for boundary confusion or harm. Casimano emphasizes discussing touch in advance. Some want none, some want to be asked, and some want the guide to initiate. She's explicit, no sexual touch, and no touching while someone is experiencing sexual sensations. Participants can say stop or pull away at any time. So for students, the point isn't touch is good or touch is bad. The point is touch is clinical intervention and ethical risk and must be handled with extraordinary care, consent, and documentation. Casimano's description of the guide is very practical. The guide isn't giving interpretations, they are doing basic needs support constantly. Things like blankets, water, tissues, a mesis bucket, helping someone to the bathroom, and assisting movement safety. And that matters because in psychedelic states, basic discomfort can become existential distress. Physical comfort supports psychological safety. She also repeatedly highlights that presence itself is therapeutic. Participants report that just knowing we were there made them feel safe to go deeper. This is a lesson in attachment and co-regulation. One of the most concrete safety lessons in the chapter is about bodily expression. Participants may experience intense movements or sensations, things like twitching, shaking, writhing, thrusting, and unusual sounds. She gives a case where a participant was terrified because nobody had warned her about body twitching. Even though the guides reassured her, she felt unsafe because she interpreted it as a medical problem. That nearly led to dropout. So in the second session, now prepared, she could relax in the same sensations and she had a profound experience. So, naming body experiences in prep isn't graphic storytelling for entertainment, it's panic prevention and meaning-making support. Casimano frames relaxation as a core skill. When fear arises, bodies tense and people brace, sympathetic activation. That makes surrender harder. So breath becomes a practical intervention. Diaphragmatic breathing, focusing on exhale, and breathing into difficult sensations. So for students, this is something you can teach clearly, practice in prep, and remind during the session. It's not magical, it's basic physiology and nervous system recognition and regulation. Integration is where meaning becomes life change. At Johns Hopkins, they had participants write a session report before meeting. So the narrative forms without guide influence. That's a research and ethics choice. Integration work helps translate insights into daily living, relationships, identity, behavior, and values. Casimano suggests less intellectualizing and more embodied and creative processing, things like journaling, movement, meditation, nature, music, and art. She also warns about disclosure. Not everyone will understand. Dismissive listeners can invalidate or destabilize. And she holds balance. Don't overhype the session, but don't dismiss subtle shifts either. The ship turns a few degrees metaphor is great for clients who feel disappointed by subtle changes. Casimano doesn't label vulnerable populations as a separate section, but it's embedded everywhere. People with cancer diagnoses, depression, trauma triggers, paranoia risk, and high anxiety are all populations requiring extra attunement and robust containment. Safety is not just no medical event, It includes psychological safety, relational safety, and ethical safety, especially around consent and touch. At the same time, there's a tension. Screening protects people, but it can also drift into gatekeeping if it becomes overly restrictive or fear-based. A clinical lens here is holding both. Access matters and protection matters. Finally, she underscores the guide's internal state. If a guide is sleep deprived, preoccupied, reactive, or ego driven, participants can feel it. So, self awareness and self care are not nice ideas, they're safety practices. So, you can say some things like notice how much of safety is created before dosing day. Also, thinking about things like in this model, the guide behavior is part of the medicine. And then I want to emphasize that as we go to the next section, track how screening is framed, whether it's protection versus access versus risk management. Okay, so into our next reading here, talking about challenging or difficult experiences using classic psychedelics. So for this reading, we're moving from how a safe clinical container is built to a population level snapshot of what can go wrong and what factors are associated with that. What's especially useful here is the sampling strategy. They recruited a US adult sample stratified to resemble the population on key demographics, and the recruitment didn't mention psychedelics to reduce self-selection bias. Then they analyzed the subset who reported lifetime classic psychedelic use. That gives us a different kind of evidence than festival or enthusiast surveys. Here's a clinical frame. The paper helps you answer a question like, what predicts difficult experiences and post-experience harm risk? And how do those predictors map onto what we emphasize in preparation, screening, and safety planning? So some method basics here. They recruited 2,822 adults in the US and identified 613 who had ever used a classic psychedelic, things like psilocybin, LSD, DMT, ayahuasca, mescaline, peyote, and San Pedro. Then they asked those 613 about challenging or distressing experiences, impairment, duration, and symptoms that lasted beyond the acute effects, and whether they sought professional help afterward. Very important because this is a cross-sectional and self-report, so we cannot say X causes harm. What we can say is X is associated with more difficulty or higher odds of certain harm indicators. That's still clinically useful for harm reduction and screening. So they did something smart. They didn't only ask one vague question like, have you had a bad trip? They asked about frequency, impairment, duration, and then used a standardized measure, the CEQ, about the most challenging experience. They also used a symptom checklist for enduring effects lasting days to longer. This matters because people can minimize distress when asked globally, but endorse it when asked specifically, symptom by symptom. In practice, this parallels clinical interviewing. Specific prompts often reveal more than a general, how did it go? Here's the baseline. Most respondents with lifetime classic psychedelic use, about 6 in 10, said they'd never had a challenging or distressing experience. But clinically, the tail matters. About 1 in 20 reported severe impairment, and about 1 in 10 had impairment that lasted more than a day. That means difficult experiences aren't rare enough to dismiss, especially if we're teaching future therapists how to screen, prepare, and safety plan. Two numbers are especially sobering for this conversation about safety. First, 2.6% reported seeking professional assistance in the days or weeks after their most challenging experience. That's not a huge percentage, but it's not trivial either, especially when we consider underreporting and barriers to care. Second, 6.7% endorse some form of harm risk indicator, thoughts or attempts to hurt themselves or others. So again, in the days and weeks following their most challenging experience. Again, in a clinical framing, this is exactly why we emphasize post-session monitoring and integration supports, especially for people with vulnerability factors. A complicated finding. Over half endorsed at least one symptom lasting a few days or more. Anxiety and sleep disturbance were common, along with difficulty thinking and deciding and feelings of disconnection. At the same time, many still agreed they were glad that they had used psychedelics. That tells us two things can be true. People can experience meaningful benefit, and they can also experience distress that requires support. So for students, don't assume meaningful means not destabilizing. Integration often has to work with both gratitude and dysregulation. So this is where the paper starts to talk directly to our topic of preparation and safety. When participants reflected on their single most challenging experience, the most frequently endorsed context factors were no preparation, a negative mindset, no psychological support, and unpleasant social or physical environments. If you connect this back to Casimano, that entire Johns Hopkins model is designed to reduce exactly these factors. So they have structured preparation, a supportive setting, and psychological support during the experience. Two more set and setting variables matter clinically. Dose was too large and major life event prior to the experience. From a screening and prep standpoint, a major life event could be grief, a breakup, job loss, a legal crisis, or a health scare, anything that loads the nervous system and meaning-making system with acute stress. Even if someone thinks psychedelics will fix it, the timing may increase vulnerability for panic, dysregulation, or post-session instability. The teaching point here is not never do psychedelics after a life event, but rather timing is a safety variable and should be explicitly assessed. This paper highlights a clinically important and sometimes underappreciated screening issue: medication co-use. About 11% reported co-use of at least one medication category during the most challenging experience. Statistically, lithium co-use and other mood stabilizers were associated with greater difficulty and higher odds of harm indicators. So for students, the key practice implication is simple. Medication review is not optional in screening and preparation, and you need to know when you are outside your scope and must consult medical prescribers. Even in non-clinical setting, harm reduction education should clearly flag medication interactions. They also asked what people did that helped during the difficult experience. The most common was trying to calm the mind, followed by changing location, seeking help from a friend, or changing the social environment. There's a big clinical translation here. These are basically informal versions of what we teach in preparation for and what skilled guides do. Co-regulation, grounding, and shifting stimulation and context when needed. So for students, prep isn't psychoeducation. Prep is also rehearsing skills, things like breathing, self-talk, orienting, asking for help, identifying a support person, and knowing when to change the environment. If I translate this into clinical practice for therapists, the takeaway is many risk factors are modifiable. This paper reinforces that no preparation, a negative mindset, a lack of psychological support, and poor environments correlate with greater difficulty, and that major life events and certain medication classes correlate with higher harm risk indicators. So screening needs to include stress timing, emotional readiness, and the practical support plan, not only looking at diagnoses. Preparation should include skills for calming the mind and help seeking. And safety planning must include what happens after. So who checks in, when, what to do if sleep or anxiety worsens, and how to access professional support if needed. This is where we connect to vulnerable populations. Clinical trials often exclude people on certain medications or with certain psychiatric histories, which may improve internal safety in trials, but it also means we have less evidence about real-world populations. This study partly addresses that gap by looking at a broader population sample of users. So for students, the ethical challenge is avoiding two extremes. The first extreme is that everyone should do psychedelics, it's all healing. And the second extreme is that if there's any risk, exclude. A more mature stance is risk formulation. Identify vulnerability factors, strengthen protective factors through preparation, support, and environment, and have clear response plans if distress or impairment extends beyond the acute period. So, reading one showed what a high support clinical container looks like. Reading two shows that what predicts difficulty when support and preparation are missing. Next, we're going to look at how screening and safety frameworks address these risks, especially for vulnerable populations. All right, so our final reading about adverse effects, call for action. So this piece is a short viewpoint, but it's doing heavy ethical lifting. Simonson and colleagues are saying the field has done a strong job documenting therapeutic promise, but it has not done an adequate job characterizing risks, especially outside tightly controlled clinical trials. So, for a clinician, this reading reframes safety as a public health and systems issue, not just an individual clinician's skill. The authors situate this paper in a moment of rapid expansion. Even before full FDA approval, access is increasing through state-level programs, underground therapy, retreats, and international contexts. Their concern is not hypothetical. Use is scaling faster than our ability to track, prevent, and treat adverse outcomes. So for students, this means you may encounter clients affected by psychedelic experiences, whether or not you practice in psychedelic therapy settings. A core contribution of this paper is expanding what we mean by adverse effects. Clinical trials often focus on acute, transient effects, things like anxiety during dosing or a headache afterward. But the authors emphasize persisting and functionally impairing effects that may emerge days, weeks, or longer after use. They also name experiences that don't fit neatly into DSM categories, things like existential struggle, derealization, loss of meaning, and social disconnection, which are especially relevant for therapists trained to think relationally and systemically. The authors are careful not to reduce risk to bad brains. They repeatedly emphasize that adverse effects emerge at the intersection of person, substance, and context. This matters for vulnerable populations. People with trauma histories, mood instability, identity fragility, or limited social support may be more affected not just by the drug, but by what meaning systems and communities they encounter afterward. This is one of the most provocative sections. The authors draw on historical observations from the 1960s that psychedelic use sometimes coincided with authoritarian or dogmatic group formation. They argue this risk may be amplified today due to digital environments, things like social media, influencer culture, and conspiracy ecosystems, especially for vulnerable individuals seeking meaning or certainty after intense experiences. So for therapists, this expands safety beyond symptom management into identity, belief systems, and social belonging. The authors acknowledge that modern clinical trials report relatively low rates of serious adverse events, but they caution against overgeneralizing those findings. Trials exclude higher risk individuals and include extraordinary safeguard. Once thousands or millions of people are treated in real life contexts, rare events become visible. This echoes a public health principle. Absence of evidence in small samples does not equal evidence of absence at scale. This connects directly to the second reading. Epidemiological studies allow us to see what happens outside idealized settings. The authors argue we need population level surveillance because even very low probability events become clinically significant when exposure increases. So for students, this is why naturalistic data matters or matter, even when it's messy and imperfect. One of the most sobering points is we don't actually have good treatments for many psychedelic related adverse effects. This is especially concerning given the rise of underground or poorly regulated practice where boundary violations, coercion, or spiritual abuse may compound psychological harm. From a clinical perspective, this means therapists may be asked to help clients with experiences we didn't cause, don't fully understand, and don't have clear protocols for. The authors are explicit. As funding and commercial investment pour into psychedelic therapies, resources must also support research on harm. They advocate a harm reduction stance, not encouraging use, but providing accurate information so people can make informed decisions. This includes being honest that psychedelics are not benign for everyone. An important subtext of this paper is cultural. The authors are pushing back against a hype cycle that frames critique as betrayal. For students, this is an ethical lesson. Caring about safety, adverse effects, and vulnerable populations is not anti-psychedelic, it's pro-client and pro-integrity. Mature clinical work holds hope and humility at the same time. So this reading kind of completes a triangle. Casimano shows that what safety looks like when done exceptionally well. Simonson 2023 shows what predicts difficulty in real world use. And Simonson 2024, the one we just talked about, asks whether our systems, clinical, regulatory, and educational, are prepared for what's coming. So together, they argue that preparation, screening, and safety are not optional add-ons, they are ethical necessities. So this paper invites a broader definition of vulnerability. It's not just about psychosis risk or medications, it's about meaning, belonging, and power. For therapists, this means screening and preparation must include social context, belief systems, and post-experience environments, not just symptom checklists. So up until now, we've looked at how safety is created, what predicts harm, and why the system is underprepared. Our final reading, sorry, I said final reading last time. This is for real, our final reading, turns to how clinicians can think responsibly about screening and inclusion, especially with vulnerable populations. So looking at some special considerations. So this paper explicitly names a core tension in psychedelic research. The populations who might benefit the most from novel mental health interventions are often the least represented in evidence base. Ortiz and colleagues are not arguing for reckless inclusion. They are arguing for intentional, ethically grounded inclusion that takes history, power, culture, and access seriously. For a clinician, this reading reframes screening and safety as justice-oriented practices. So the authors use a broad public health definition of vulnerability, under-resourced social groups at higher risk for poor health outcomes. Importantly, vulnerability here is structural, not synonymous with individual pathology. This distinction matters when we think about screening. Are we assessing risk or are we responding to inequity? This paper does something many clinical readings avoid. It directly names the historical harms tied to psychedelic research and use. For many vulnerable communities, psychedelics are not new and exciting. They are associated with exploitation, coercion, surveillance, and cultural theft. The clinical implication is profound. Mistrust is not resistance, it is contextually rational. The authors explain why recruitment disparities persist. People with higher socioeconomic status are more likely to encounter psychedelics through positive media narratives, books, podcasts, and clinical disclosure. Meanwhile, vulnerable populations may associate psychedelics with criminalization, punishment, or cultural erasure. This means that neutral recruiting strategies are not neutral. They privilege those already positioned to feel safe, engaging. The authors are clear. Ethical inclusion requires focused recruitment in partnership with trusted community organizations. This is not just about numbers. Community engagement can help shape study questions, procedures, and outcome measures so they actually reflect participants' lived realities. For clinicians, this translates into how we talk about psychedelic work with clients. We talk about things like clarity, humility, and respect that are all safety practices. The authors caution against using overly academic or mystical language when preparing participants. Terms like mystical experience may not resonate or may feel alienating to people with different educational, cultural, or religious backgrounds. The safety implication here is misunderstanding the experience increases fear, confusion, and distress. Preparation must meet people where they are linguistically and culturally. The authors emphasize that many vulnerable populations hold strong religious or spiritual worldviews. Trivializing or explaining away spiritual meaning can rupture trust and undermine integration. Clinically, this aligns with culturally responsive care. Safety includes honoring how people make meaning, even when it differs from our own frameworks. A critical insight in this paper is the intersection between structural powerlessness and psychedelic vulnerability. Psilocybin often requires surrender, but for people whose lives already involve coerced surrender to things like systems, institutions, or authority, this can be terrifying rather than healing. The authors argue that therapeutic alliance is the key moderator. When people feel respected, informed, and empowered, surrender becomes possible rather than re traumatizing. The authors offer a nuanced take. Matching therapists and participants by race, gender, or identity does not automatically improve outcomes. What does matter is multicultural competence, the ability to reflect on one's own positionality, understand power dynamics, and respond with cultural humility. This is a key teaching moment for students that competence is not about identity matching, it's about how you show up. So current psilocybin protocols are demanding. There's multiple prep sessions, long dosing days, follow-ups during business hours. So many vulnerable populations, these requirements, for many vulnerable populations, these requirements make participation functionally impossible, regardless of interest or potential benefit. Exclusion based on comorbidities further compounds inequity because these conditions are more prevalent in under-resourced groups. So this slide is where the authors move from critique to practice. It's important for students to hear this not as idealistic suggestions, but as ethical design principles. First, the authors point out that current psilocybin protocols are time-intensive by design. There's multiple preparation sessions, an all-day dosing session, and multiple integration meetings. While this structure may maximize safety and therapeutic alliance, it also unintentionally excludes people who cannot take time off work, arrange childcare, travel repeatedly, or tolerate rigid scheduling. So when the authors suggest reducing the number or length of sessions where possible, they are not advocating for cutting corners. They are asking which elements are essential for safety and alliance, and which are historical artifacts of early trials. This is a critical clinical question, especially as access expands. Second, offering evenings and weekends. Telehealth components or mobile-based integration is framed as a safety strategy, not just a convenience. When people are forced to choose between participation and basic survival needs, participation itself becomes coercive or destabilizing. Third, compensation deserves special attention. The authors emphasize that compensation should reasonably cover time, transportation, and related costs without becoming coercive. This is an advanced ethical tension for students. Underpaying exploits labor, overpaying can pressure participation in ways that undermine consent. Safety includes economic ethics. Finally, the authors encourage researchers to reconsider overly conservative exclusion criteria. Early psilocybin trials understandably erred on the side of caution, but those criteria disproportionately exclude people with medical and psychiatric comorbidities, precisely the conditions that cluster in vulnerable populations. So the key teaching point here is nuance. Safety is not achieved by exclusion alone, it is achieved by matching risk with support. This slide is where we see the readings are not four disconnected articles, but a single argument unfolding across levels. So in reading one, It shows what safety looks like at its best: intensive preparation, relational containment, clear boundaries, and deep respect for the participant's inner process. Importantly, safety is not located in the drug itself, but in the relational and procedural container. The second reading zooms out and asks, what happens when those supports are missing? The answer is not catastrophic for most people, but risk clearly increases. Lack of preparation, poor setting, high stress timing, and medication interactions all correlate with distress, impairment, and post-experience risk. This reading underscores that safety failures are often contextual, not individual flaws. The third reading then widens the lens again to a systems level. As psychedelics move toward broader access, the authors argue that we are collectively underprepared for adverse effects, especially those that are rare, delayed, or socially mediated. This is where safety becomes a public health issue, not just a clinical skill. Finally, the fourth reading asks the hardest question: who is being protected by current safety practices and who is being excluded? This reading reframes safety as inseparable from equity, history, culture, and access. If safety protocols systematically exclude those with the highest burden of suffering, we have we have to question whether those protocols are truly ethical. These four readings together suggest that psychedelic safety is relational, contextual, and structural, not just pharmacological. So first, safety is not a checklist. It is not achieved simply by ruling out diagnoses, following a protocol, or saying we inform them of the risks. Safety is co-created over time through preparation, transparency, alliance, cultural humility, and responsiveness. Second, screening deserves to be reframed. Screening is often experienced by students as gatekeeping, deciding who is allowed to participate. But the authors invite a different stance. Screening is care. Good screening asks, what risks are present? What supports are available? What additional supports would be needed for this to be ethical? Sometimes the ethical answer is not now or not in this setting, but that decision should be made transparently and collaboratively, not paternalistically. Third, preparations should be explicitly named as an intervention. It reduces fear, increases agency, supports surrender, and prevents harm. When preparation is rushed or minimized, risk does not disappear, it simply goes uncontained. Finally, vulnerability is not a reason for exclusion, it is a reason for greater care. Vulnerable populations do not need less access to psychedelic therapies. They need better designed, culturally responsive, ethically grounded containers. So, the goal of psychedelic therapy is not just healing experiences, it is healing systems, and safety is where that work begins.